Hi there, this is Dr. Monica Agarwal bringing you another episode of Seeking Voices, exploring the science of health and healing. I had the pleasure of interviewing a fantastic woman today, Dr. Kristi Funk. Dr. Kristi Funk is a board-certified breast cancer surgeon and physician. She's the best-selling author, an international keynote speaker, and a women's health advocate. Let me tell you a little bit about her so you can get to know her and realize how credible and awesome she is. She graduated from Stanford University in 1991, got her medical degree at UC Davis. She completed her surgical residency in Seattle, Washington, her surgical breast fellowship at Cedars-Sinai in Los Angeles. She soon became the director of the breast center there until 2009, and then co-founded the Pink Lotus Breast Center in Los Angeles, where she practices as a breast cancer surgeon, an expert in minimally invasive diagnostic and treatment methods for all types of breast disease. She's helped thousands of women navigate breast issues, including well-known celebrities like Angelina Jolie and Sheryl Crow. As an ambassador and an avid contributor to the Pink Lotus Power Up community, Dr. Funk hosts a cooking show in the Cancer Kicking Kitchen. She frequently authors Breast Cancer 101 blogs and provides instructional videos on breast health. Her extensive research in nutritional science caused her to expand the passion for her medical practice with Life Empowering Cancer Kicking Summit, where she teaches women and men how to maximally reduce their chances of facing cancer and other controllable killer diseases. She's the go-to expert for Good Morning America on breast disease and Dr. Phil's Merit Street Media. She was a co-host on the TV show The Doctors, has repeatedly appeared on the Today Show, Rachel Ray, The Dr. Oz Show, CNN, and The View, and more, as well as countless radio and podcast interviews. She's received dozens of honors and awards and uses her appearances to educate and give back to the community. She lives in Los Angeles with her husband, Andy Funk, and has triplet sons. How crazy is that? I really enjoyed speaking to Dr. Funk today because we got a chance to talk about breast cancer, breast screening, mammograms, MRIs, breast biopsies, because we're seeing such an insurgence of these biopsies. I wanted to just talk through what you can do to reduce your cancer risk. And so Dr. Funk has a lot of experience as a surgeon, trained in allopathic medicine, but also has such a significant passion and interest in education, in nutrition and lifestyle to heal the body. I'm looking forward to hearing your thoughts on her. Stay tuned. So great to see you, Kristi. I'm so glad you could be on my show. Thank you so much for being here.
Monica, thanks for having me. Can't wait.
It's my pleasure. So I thought it would be fun for people, especially on the East Coast, which are where I am, who don't know you as well, maybe you can tell us a little bit about you and what you do and how you get started in this very interesting work you're doing.
Sure. So I'm born and raised a California girl. I went to Stanford undergrad and UC Davis in California for medical school. I trained in Seattle in general surgery. So that's a 5-year stint. And after that, I was thinking, you know what, I want to do minimally invasive surgery. It was the year 2000 and laparoscopic surgery had just started. So I actually got edged out of operating by the attendings because they needed to figure out how you take a gallbladder out using these instruments and watching a TV screen. So I knew that was going to be a big future for surgery. And I came back home to Los Angeles to work at Cedars-Sinai Medical Center in a minimally invasive surgery fellowship. And while I was there, when I first started, 2 weeks in, the same surgeon who headed up the MIS fellowship was director of the Cedars-Sinai Breast Center.
What's the MIS? Just for
minimally invasive surgery.
Yeah. Mm-hmm.
So the laparoscopic stuff. And he said, I never asked you what you really wanted to do when you're done with your fellowship. Let me tell you what you're going to do. You're going to do, no break. Didn't breathe. And I'm going to tell you what you're going to do. You're going to actually switch to a breast surgical fellowship, and then you're going to help run the breast center here.
I was okay,
that's interesting because that's so far away from the stomach and esophagus, which is what I loved. So anyway, he's like, I understand that this is springing it on you, so take your time. Just let me know by Friday.
I love
And
it.
so that's how that went down. And it took a little bit of soul searching. Well, I only had till Friday to search my soul, but I did. And really, I have to kind of preface, I just finished a general surgical residency. So for 5 years, this is before there were residency hour restrictions. I was working like 100 to 120 hours a week, like just learning. I could crack your chest open and have your heart on bypass. I could take your colon out. Like I had so many skills. And breast surgery just seemed a serious underutilization of them and quite easy, frankly. So I didn't come to this other fellowship to do breast surgery, right? So it took me, honestly, some true reflection to be like, what do I want out of my career and where do I see this going? And it became readily apparent that, wow, I could have a true depth of knowledge in this one area of breast disease and be a true expert in it. And while I might think breast surgery is easy comparative to all the things I can do, it is nothing but easy for a woman diagnosed with breast cancer. And if I can come alongside her in this dark moment and provide some guidance and wisdom and experience and make her journey easier, then I will have a satisfying career that hopefully keeps me from feeling burnt out and, always energetic and excited about my life. And so I did do exactly that. They had no breast fellowship at Cedars-Sinai. We created it. I was their very first fellow. And this would be 2001. And I finished that and did exactly what he had envisioned. I was one of the directors of the Cedars Breast Center for almost 8 years before my husband and I together co-founded the Pink Lotus Breast Center. So I've been the head of this breast center now since 2009, which really combines a lot of compassionate and holistic care with state-of-the-art screening and surgical technology. So it's been a wild ride. I really love this kind of singular focus of breast disease because it's turned out to be anything but singular focus. The stuff that I've come to learn, which is the second part of your question, is how did I get into like more of a plant-based lifestyle medicine?
Yeah, and really this holistic practice. I mean, that's not how you trained. That's not what you were focused on. How did you get into it?
Right. So it started back at Cedars-Sinai when I was director of patient education. I'd go out and give these lectures to maybe 10 people who showed up there for the free pens, halfway sleeping in the back. Like it was not fun, but it was like part of the job to like go out in the community and do this lecture. So I started to jazz up the talks a little bit because what I realized is no one wants to hear about the breast, like this is breast cancer. Here's what you can do to treat and cure it. It's only interesting if you yourself are in the throes of making these decisions or you're helping someone else make them. Otherwise, it's TMI and people don't want to hear the details of breast cancer, but they do love to hear about risk reduction. So I started to learn things like, did you know that the EGCG in green tea can decrease breast cancer recurrence by 57%? Like they were just factoids though. I hadn't put it all together as a powerful tool for helping people mitigate breast cancer risk and then navigate a breast cancer diagnosis to help reduce recurrence and improve outcomes until I wrote my book. So I wrote a book that published in 2018. It's called Breast, the Owner's Manual. And when 80%
the owner's manual, I always love that. So just so you hear that again, it's called the owner's manual.
Right. Thanks. It was funny. I reached out at friends with Dr. Oz, and at the time he had his show and everything. And I was like, can I send you a draft copy? Do you mind writing an endorsement for the book? And I had not realized after I asked him, I, out of curiosity, was just looking up his books. He has a book called You, the Owner's Manual. And I was like, oh no, he probably thinks I totally stole that with my version. I was like, I honestly didn't even know. But anyway, I was writing that book and everything in it, I backed up with scientific fact and references in the back, over 5,000 of them. Because, well, first of all, I didn't want to be spreading falsehoods. Second of all, I knew bullets would fly at the book and I wanted it to be bulletproof with these scientific references. And also I just love to be right, which makes me delightful to be married to. So I in so doing, dove into nutrition science for the first time in really my whole life. I had no idea what I would uncover there. I don't know the particulars of when you had your like come to kale moment, but
Yeah.
mine shocked me because, as we both know, none of this is taught in the med school days. So we come to it on our own. And I thought, it was really just fake fact in Leafy Green magazine kind of stuff. Right? New England Journal of Medicine, JAMA, Lancet, like all these reputable peer-reviewed journals carry such weighty data on the power of plants to truly reverse disease inside of us, and also how detrimental animal protein and animal fat is to create disease processes inside of it. So that was my real eye-opening moment, was that there's strong fact and data, human data, showing that there is a best way to eat. And you can extrapolate that even further. There is a best way to live when it comes to looking at beyond diet, exercise and body weight and environmental exposures, whether you fast or not, whether you take hormones or not. All of these things interact in a complex way inside of you to promote health or to destroy it.
Yeah. So I love so many things that you said. And I think that I like, so I started this podcast, on a whim, because was driving me crazy that there's so many people out there that are talking trash medicine, or just, they don't have any scientific background, and they're saying stuff. And then there are people out there that haven't really read the data. And I really wanted to get true scientists on this show to say, like, you know what, whether you believe or not, I want the people that are experts that are on here just talking about the real science. Like, does this work or not? What do we know? What's the data? And so I appreciate you saying that, and that you went through this revelation. I certainly went through a similar revelation when I got sick, but I had to get sick to understand how to get better. And when you're told that you have incurable illness, or that you can't do anything at all, or you just have to take medicines and get used to it, you start finding your own ways. And certainly had to go through something similar. So let's get into this, because this is super interesting to me, is what you're working on, what your space of breast cancer. And I will share with you, maybe to start, is that as I've gotten older, I have large breasts, I have fibrocystic breasts. And I had a recent mammogram that was abnormal, which led to a ultrasound, which led to a breast MRI, which led to a biopsy. And so I kind of want to talk through first, maybe I jumped the gun there, and maybe we should step back and say, let's talk a little bit about what is breast cancer for people listening, and why are we seeing more breast cancer than we did 20, 30 years ago? And why do you think that is? Maybe let's start there, and then we can get into some of this testing and why, are we over testing, under testing, et cetera?
Okay. Lots to unpack there.
Lots to unpack.
So what is breast cancer? All cancer is a normal cell that's now gotten its DNA damaged, and that damaged version of the cell proliferates, 1 becoming 2, becoming 4, and so on, until you have a detectable wad of damaged cells. And these cells, by definition of the damage, no longer respond to the checks and balances within your own body, right? There's a reason why, like, the skin on your finger doesn't like grow and grow and grow and overgrow into some like growth of too much skin, because your skin cells are normal. And there's natural like apoptosis, cancer cell suicide, or just not just cancer cell, but normal cell, like
cell suicide. Yeah.
Mm-hmm. You're senescent now. You're too old. You're buzzing around. Your immune system comes in and says, "Yeah, you did a good job, my friend. It's time to go." Right? Tears it down, rebuilds cells, and that checks and balances happens all day long until a cell escapes those mechanisms of keeping things contained. So in the breast, the vast majority, 75% of breast cancers, occur within these hair-thin, tiny ducts that carry milk when it's time to breastfeed, down through the breast tissue and out the nipple. On the other hand, 15 to 20% of breast cancers form in the milk-producing lobules of the breast, and then 5 to 10% is weird stuff and rarer cancers. So the vast majority of cancer in the breast is happening in ducts and lobules, and it's simply starting off where we just use a duct, like an intact tube. You get this overgrowth of weird cells. That's where you may run into biopsies that you have that have words like hyperplasia, atypical ductal hyperplasia, atypical lobular hyperplasia, radial scars, papillomas, just odd things that are happening from too much stimulation, but they're not yet cancer. When those cells are atypical by a pathologist's eye, like their definition of atypical has to do with the morphology, the shape of the cell and the size of the nucleus and such. But that atypia starts to encroach upon the whole inside of the duct and then starts to widen the duct. When it's 2 millimeters or more in width, that becomes breast cancer. So the very earliest form is ductal carcinoma in situ, or DCIS. And I want to stick a pin in that and come back to it because this is kind of a serious area of overdiagnosis and overtreatment, in my opinion. And I hope to shed some light on that. But that's in situ cancer, standing in place inside an intact duct wall. Therefore, these cancer cells cannot access the lymphatics in the bloodstream, which are on the other side of the wall.
Okay, so a safer cancer almost because it's just sitting in there. And remember, if it hits the lymphatics, that's when it spreads out to the body.
Exactly. So to get to those lymphatics, it has to invade or break the duct wall. So an invasive ductal or an invasive lobular, same story, but the milk lobule, cancer can now potentially access both lymphatics and spread or straight to blood and spread. And now invasive cancer is categorized, staged based on how it's sized in the breast. So if it's under 2 centimeters and didn't go to nodes, it's stage 1. And if it's somewhere between 2 and 5 centimeters and didn't go to nodes, it's stage 2. And then there's like variations there of how big it is and how many nodes are involved into stages 2 and 3, because there's A, B, and C. And then if it's spread to lung, liver, brain, or bone, that would be the most common distant metastatic sites that breast cancer wants to go. Now we're dealing with stage 4. So that's cancer in a nutshell, Cancer 101.
Yeah, it's good. It was good.
One more thing to say about that, because this is where the fun starts in terms of my understanding of how I can help people manipulate their diet and their actions to deal with the cancer based on what it loves and doesn't care about. So in other words, tumor profiles, they have to do with the receptor status on breast cancers. 80% of breast cancers are fed and fueled by estrogen. So there's like this little antenna sitting on the outside of the cancer cell. When estrogen, we'll talk about different sources because it could be your own ovary, it could be hormone replacement, it could be soy. But if estrogen hits this receptor, it's going to send a signal to the cancer to multiply and divide. So again, 80% of breast cancers have this receptor. Then there's a receptor for progesterone, another common hormone that's coming from our ovaries. So there's a third receptor we look for called HER2, which is a growth factor. And so depending on which receptors are present or absent and how they are quantified, because it can be anywhere from like 0 to 100% present. So you might have a 65% estrogen positive, which means 35% of the cells could care less about estrogen. And that really dictates treatment down the road, in addition to genomics, not genetics, like do you carry a BRCA mutation, but the genetic mutations within the cancer itself. This is the current way that we really understand what drives this cancer, and therefore what we recommend to try to kill the cancer.
Yeah, so you're talking about a lot of different things, which are great. So the genetics predispose us maybe to getting the cancer or not. Mm-hmm. The genomics is what we see when we look at the cells and the markers and really tells us how we're going to treat the cancer.
Exactly.
Okay. Yeah. So go ahead.
Well, yeah. I'm remembering that your next part of the question was like, so it's on the rise or on the decline? Like, where are we?
Yeah, exactly.
State of the union here. And it doesn't look good, people. So in 2020, breast surpassed lung cancer to become the #1 malignant tumor on planet Earth. And the numbers, particularly in the US, are going up and up and up every single year since 2012. An average of 1% per year rise year after year in the number of cases diagnosed. And since 2012, 1.4% per year increase in women under 50. So the numbers are overall going up and the ages are getting younger. So what is going on? Because you have to realize.
Yeah, that's great. So, because initially I would have said, oh, it's just that women are living longer. But now you're saying actually that there's a higher prevalence in the under 50 range.
Exactly.
Hmm.
And I think it's multifactorial for sure. But one thing for everyone to remember is that number one, only 5 to 10% of all women diagnosed with breast cancer have an inherited genetic mutation, such as BRCA, CHEK2, PALB2. You may have heard of these. They create a very high risk from something you've inherited from a mom or dad, high risk situation to get a breast cancer. Only 5 to 10%. Now, that's not to negate that gene mutation, when present, is serious, and we need to take surveillance extra serious
Carefully,
with.
yeah.
Yeah. So but I'm not dismissing gene mutation carriers at all, but I want to emphasize that means 90 to 95% of all women with breast cancer can't blame inherited genetics. And
yeah, so it's something polygenic plus a combination of a lifestyle, or what do you think?
To give it one word, it would be epigenetics. So this is how your everyday choices about what to eat or not eat, drink or not drink, whether you're going to move or not move, whether you're going to think or not think something, forgive or not forgive someone, all of these choices that we're making, plus the environmental exposures, right? We live in a ubiquitous environment of pollutants, but we can talk about how to control what you can and kind of forget the rest. But anyway, all of these choices and exposures alter how there are different genetic switches inside of us. They're called proto-oncogenes. So proto-oncogenes are like normal cells. They're just humming along. They divide and they're normal and they're in the checks and balances that I mentioned earlier. And then there's a whole nother group of genes called tumor suppressor genes. And just like it sounds, they suppress the growth of tumor cells. So, whoa, hey, hang on there, proto-oncogene. Seems like you've made a little mistake. So the tumor suppressor would tap on the brakes, stop this car for a sec. Let me get out. Let me tinker with you, fix you, throw you out because you're too deranged. Or, oh, there you go. You're all fixed. Go on your merry way. And you step on the gas a little. And that's the checks and balances picture. When you make too many harmful choices that overwhelm this system, the proto-oncogenes, little gas pedal of cell turnover, can just put on that gas so fast and so continuously that now the cells are turning over really, really fast, and then they make a mistake, and then the tumor suppressors can't stop it, and you got this mutated gene that's going from, again, 1 to 2 to 4 and so on, and boom. What? This mass wasn't in my breast last week. What is this thing I'm feeling? And that is what's now an oncogene. So you turn something normal into just full-on gas pedal to the metal. And our choices influence that whole process. So it's quite empowering once you know which choices lead to the best, healthiest cellular life.
So that's an interesting comment. So, you're talking first, you said earlier that eating plants matters. There's all these vegetarians out there that are getting cancer. I mean, why are they getting cancer? And eating plants is the treatment. Explain that a little bit.
Okay, so the difference, of course, first of all, I want to just preface that vegans get breast cancer too. And generally, in the absence of an inherited mutation like BRCA, I find that both vegans and vegetarians generally, for the most part, get a cancer that's quite manageable. It doesn't divide that quickly. It usually loves estrogen. These are slower growing, more curable cancers as opposed to their opposites, estrogen negative and dividing quickly. But we can see in some data that vegetarians do have higher breast cancer rates than vegans, largely then because of the dairy and possibly eggs that they're eating. So deadly dairy sounds a little dramatic. There's a lot of benefits to dairy. And when you look at studies in terms of breast cancer risk, they kind of fall all over the place because there are healthful properties in most dairy, right? Like you've got butyrate and calcium and vitamin D and linoleic acid. But on the other hand, you've got aflatoxins and pesticides and the herbicides and GMO feed and all the stuff that the cow had, eaten before it gave you this milk, which, by the way, 2% of which in America is totally illegal to be pus, pure pus. And that's because there are, just like human women get
Mastitis or
Mastitis and abscesses, though. They get abscesses, right? And you got to, as a surgeon, drain that pus out of the breast. Well, they don't really bother with that for the poor cows that are lactating, get abscesses all day long. So it just drips pus straight into it. And it's like too much work, I guess, to separate it out. So your milk carton that you get at Ralph's or your local supermarket, 2% pus, totally legal. So anyway, you would think that the combination of these two things might actually lean one way or the other, but there are studies that you could kind of, if you want to cherry pick, you could make an argument pro dairy or anti dairy. But as a generalization, there are
more negatives than positives. It sounds like
so, for sure.
Yeah. So, like, what plants are important to eat? Any plant? Because you also brought up soy, and you said soy is actually, we know that soy is a phytoestrogen. So, are these all plants that are good for us? Is soy okay for us? Tell us a little bit about this.
Yeah, let's dispel some myths. So, all plants, save the poisonous ones, are absolutely good for you and beneficial. And let's dissect soy as an example of one that's been vilified repeatedly, especially with respect to breast cancer. Turns out, I mentioned that whole estrogen connection to cancer fuel, right? There are actually 4, but we'll just focus on 2 main estrogen receptors inside of us, alpha and beta. Alpha is on the cancer cell that, when inhabited by estrogen, accelerates proliferation and growth of the tumor. Beta, on the other hand, can also be on a cancer cell, but with 1,600% more affinity. The phytoestrogens in soy, so isoflavones such as genistein and daidzein, 1,600% preferentially zoop over to the beta receptor. And so now when beta is activated, it does so many fabulous things. First of all, it shuts alpha down. So now it's anti-proliferative to that same cancer cell. Second of all, it goes out to your fat cells where you have an enzyme called aromatase. Aromatase is busy converting precursor steroids from your adrenal gland, like testosterone and androstenedione, into estrogen. And these plant phytoestrogens turn aromatase off. So you're getting less conversion into estradiol, which is then hitting alpha and fueling cancer. If this is all true, then it should be true that high versus low soy milk consumers have less circulating estrogen. And this very test was done in Texas. I guess they don't drink that much soy milk there. And what they did was they gave premenopausal women, because we need estrogen levels that are high enough to actually see some fluctuation and change, 3 cups of soy milk daily for 1 month. And what they found was, so they did blood draws before the drinking of the milk, soy milk. And then afterwards, what they found was, depending on where women were in their menstrual cycles, 100% of them had between 30 and 80% lower estrogen. And that effect lasted for 3 months. So we're seeing, okay, yes, that's just one study that showed that mechanistically, it does seem that soy is decreasing the aromatase conversion, because obviously it's not going to go shut your ovary off. So it's purely the aromatase conversion that's getting decreased. The bigger question is, do studies show that it decreases breast cancer incidence? And in fact, there are multiple studies that generally show between a 25 and 60% decrease in breast cancer occurrence for high versus low soy milk consumers. Every single human study ever done looking at soy consumption and breast cancer has infrequently shown no effect, and almost always shows a positive effect, meaning decreasing cancer risk from occurring, and if you've already had breast cancer, from it recurring and from you dying from it. Not only estrogen-driven cancers, but actually it's even more powerful, it being soy consumption, in estrogen-negative cancers. So the bad rap really came from, I think, the mouse models that were used in the 70s and 80s. Yeah. And what they did was they graft breast cancer cells onto mice, feed them soy, and they grew. So that was enough for me for 18 years as a breast cancer surgeon to say, like, hey, spit that miso out of your mouth. What are you thinking? Like, you can't have soy. This receptor isn't discriminating on what kind of soy. One, we humans metabolize isoflavones differently than mice. That's something that came to light. And
Yeah.
number two, this whole, oh, there's a beta receptor as well as alpha. So this whole connection happened. I lecture a lot, and I have like a number of slides that I go through that talk about all of these studies, but I'll just kind of hone in on one because it's nice, because it's very large and multi-ethnic, and fairly recent. It came out in 2020, and they followed just over 52,000 North American women for 7.9 years. And 29.7% of the women were Black. So I love we have our African American sisters represented in this good study. And in that time, we had 1,057 new breast cancer cases arise. When they analyzed dairy consumption versus soy milk, what they found was a 32% drop in breast cancer for your median. So there's, the average consumption of soy milk versus dairy milk. That's dramatic. But when you just compare cow milk drinkers, highest versus lowest percentiles, the high cow milk drinkers had 50% more breast cancer than the lowest cow milk. So there's no soy involved there. It's just milk is not doing a body good.
Yeah, so I think so, such important points, because you're not only saying that dairy is bad, but that soy is good. So it's actually twofold benefit, because you're taking away something detrimental and you're adding something that's good and supportive. So is there a too much? Is there a too much soy? Can you eat soy? Can you eat tofu every day?
Yes, I want you to have, if you're really aiming to beat back some breast cancer risk, 2 to 3 servings of soy a day. There is too much of a good thing. I've done some research trying to figure out, is there a level of soy protein which will elevate IGF-1? So for those of you unfamiliar with this bad boy, insulin-like growth factor 1 is the biggest growth promoter inside our body. So it screams at all your cells to grow, and grow they will, which is wonderful because we actually turn over 50 billion cells a day that need replacing. And of course, children need to be growing, literally. But whenever you eat animal protein, you spike your IGF-1, and even in small quantities. So that elevated IGF-1, well, we already did the cell turnover deal today. So now what are we going to do? Oh, there's a breast cancer cell. Let me have it grow metastases into the liver, into the lung. IGF-1 just screams at everything to grow fat, grow plaque, grow more tumors.
Yeah.
So is there this finding in plant protein? And I found that yes, for 6 servings of soy a day, and 3, 4, and 5 servings, 3 and 4 servings seem fine, and 5 I couldn't find data on. So I just limit it to 2 to 3. Seems like 4 is okay, but why do that when we're sure 2 to 3 is fine?
And just for the audience, how much is a serving in that situation?
It depends. So a cup of soy milk would be a serving, whereas a half a cup of soybeans or tofu or tempeh would be a serving.
Yeah. So I think that's great. I think it's really important for people to hear that from you in particular, that there's alpha and beta receptors, that alpha are sort of the cancer ones and the betas are actually the anti-cancer ones, and that the soy attaches to the beta. So it's like an anti-cancer, but that there is a point, so that we do want you to eat a lot of soy and an abundance of soy, and up to 3 servings, maybe 4, 3, 2 to 3 at least, we'll say.
Yeah.
2 to 3 servings of soy per day, which is more than most humans are getting, is fine. But we probably don't want to eat up to 6 servings per day, or anything really above 3 is probably maybe too much. Because maybe we don't have enough data on that sort of 4 to 5 area, and then 6 certainly is too much. Does that sound about right?
That sounds right. And for any men out there and anyone else wondering about other issues, Dr. Mark Messina published a really great meta-analysis of 417 human studies looking at soy consumption and a number of medical issues. This came out in 2021, and they determined that all soy is not an endocrine disruptor, which means it's not going to have any adverse reactions or alterations in your thyroid function, in estrogen levels, as we discussed, ovulation in women, semen levels in men, and no negative effects in children, specifically little boy boobs called gynecomastia.
Right.
For which, again, soy
That's
has been.
good. I'm so glad you said that, because it's so important to talk about because we all hear as physicians that if I give my kids soy, they're going to get, breasts, or that my husband is going to develop breasts, etc. So I think it's important to say.
Actually, what you can feed your kids to give them breasts as little children? Beef. So there, in Italy, in Milan, they found it was 1981, where all these 3 to 10-year-old little boys and girls started sprouting breasts, and they tracked it back to the zeranol in beef. Zeranol is literally the most potent synthetic estrogen on planet Earth. And it has the estrogen potency that is 100,000 times the estrogen mimicking ability as the BPA in plastic, right? So I always kind of smirk when someone who's like eating an In-N-Out burger and they're like, oh, I'm not drinking out of that plastic water bottle. That may have been in the sun. They're chomping on their burger. So actually, in 1987, the whole EU, which wasn't called the EU back then, banned zeranol from meat, but they also banned all importation of meat from the US and Canada, because to this day, 94% of our cattle are injected with zeranol, because as a potent estrogen, it makes cattle grow fat fast. And we only have like 18 months, people, before this thing's going to slaughter. So yeah, zeranol is how you can give your sons little boy boobs.
Yeah, no, this is great. So you made one comment that I want to kind of suss out a little bit. You said that when they tested the estrogen levels when people ate more soy, it was 30 to 60% lower when they tested this. Now, are we saying that soy is hastening our arrival to menopause because we are removing estrogen, or the estrogen levels are lower when you drink more soy?
No, because you're not impacting your ovarian function at all.
Okay.
So you're still making the estrogen manufacturing feedback loop is still intact, right? Your ovaries are making enough estrogen. Your brain is sensing there's enough here. Otherwise, it'll send out more follicle stimulating hormone to the ovary to be like, hey, make some more estrogen. She needs it. But instead, you're just tempering levels to what your body actually would desire.
Yeah, I think that that's such an important point, because I know that that's something people are going to ask me and put in the comment section for sure. So I'm glad you said that. So I got distracted because I got excited about the soy and about the diet and eating plants, and I want to go back, if we could, to diagnostics. Diagnostics. And because I just find the process, and as I'm aging, I'm just noticing that more of my friends are telling me that they're also going through this process where they're getting these abnormals. And I realize that we are, I'd like you to kind of go through a little bit, because we know that breast MRI is more sensitive, less sensitive, and more specific, correct? When you do, it's, and mammography is, breast MRI is less sensitive. I'm getting myself.
It's the most sensitive.
Most sensitive. Yeah, sorry, it's most sensitive.
Yeah.
And if you could talk a little bit about sensitivity, should we, and maybe actually step back, because a lot of plant-based people, or a lot of sort of nutrition and lifestyle-based people, don't want to get mammograms because they don't want the radiation. And maybe start there. Should we be doing mammography at age 40? And maybe start there.
Okay. Yeah, I have all the answers for you. So let's start there with the real question, which is, do mammograms save lives? And you can, again, pull out individual studies, and I can tell you, no, they don't seem to, or at least in this age group, they don't, and here they do. But as a sum total, there's a lot of compelling evidence that at the end of the day, yes, mammograms do save lives. When they first came into existence in the 70s and then were full force in use in the 80s, we had a number of studies that showed on average a 20 to 25% drop in mortality from breast cancer being diagnosed at an earlier, more curable stage via mammography instead of waiting until you could feel it. Caveat, same period of time, tamoxifen was discovered. So this is a very potent anti-estrogen pill that women can take, and maybe that was leading to the decrease in mortality. So a little bit of a confounder there. I think most of us in the plant-based world, at least we doctors, are very familiar with the IARC, the International Agency for Research on Cancer, right? This is part of the World Health Organization. Their sole job as researchers who are not paid under the table by big Aggie to be pro-meat or by big pharma to be pro-mammograms. They're allegedly just objectively looking as scientists at the data, telling the world what does and does not cause cancer, right? So for many of you out there that may not know, for example, the IARC in 2015 ruled that all processed meat, absolutely carcinogenic to humans, all sausages and bacon and hot dogs and your entire charcuterie board, as the proof is as strong that it is carcinogenic as the proof is for tobacco, alcohol, asbestos, plutonium, processed meat.
Processed meat, baby.
Red meat probably is carcinogenic to humans. We know it's tied to colon cancer. All right, so this is an organization that we, particularly in the plant-based community, really trust. So let me tell you what they found in that month prior, June 2015, when they had an independent global review of all of the available peer-reviewed data on mammograms. The question was, did they save lives or not? Like, just bottom line it for me, people, right? And so after reviewing all that data, which amounted to 20 cohort and 20 case controlled studies, caveat, conducted in high income countries. So we were talking about Australia, Europe, and North America. What they found was that there was, in fact, sufficient evidence to say that mammography screening is effective at reducing mortality, particularly in women 50 to 69 years old, for annual mammography. And that the reduction in mortality was to the tune of 40%. Mm-hmm. However, there was still a reduction up to 74 years old. And when they looked at the 40-somethings, so 40 to 49, screening effectiveness was the data was limited. So they didn't conclude anything for those in their 40s. But for sure, 50 to 74 years old, mammography saves lives. Now, on the flip side, mammography has a lot of drawbacks, and you were victim of one of them, which is the false positive callback. So the main drawbacks of mammography, in addition to the discomfort of, squashing and just disliking it, are false positive results, which we'll detail, overdiagnosis, meaning finding a cancer that was going to kill you when you were 210 years old, but now you know about it. So what are we going to do about it? Leading to problem 3, overtreatment. This cancer wasn't going to kill you. And now here we are talking surgery, radiation, chemo, antiestrogens, biologics like immunotherapy, Herceptin. So that's a huge thing to kind of address. And then the fourth and final one that you mentioned is radiation-induced breast cancer. Mammograms create ionizing radiation flying through your breast tissue, and we know that ionizing radiation causes cancer. Do mammograms cause breast cancer? Yeah, they actually do. So if you do computerized models, if you take 10,000 women and they get annual mammograms from 40 to 74 years old, you will diagnose 860 breast cancers, and all those mammograms will have caused 8.6 breast cancers. So in other words, we're finding 100 times more than we're causing, but the answer is yes, mammograms do cause breast cancer.
But of that 800, it's like 1% are caused by the radiation.
Yeah. Right. Yeah. So we find, 100 times more than we cause with the mammograms.
Yeah.
So I have a couple more thoughts I wanted to throw out, and then I'll just kind of wrap it with a bow. So first of all, it's easy for me to say don't fret if you're called back, but you should know that you were in really good company, Monica, when you got called back for your mammogram. So it turns out we end up calling back about within 10 years of annual mammograms, 40 to 50% of women will get called back at least once in that decade. So it happens a lot. And when you're called back, 97% of people called back do not have breast cancer.
Yeah, wow.
So when you're called back, you're going to get extra views, usually of a mammogram. They want to squish harder and magnify an area of concern and maybe ultrasound spot check that to be like, is there anything lurking in there or not, because of what we saw on the mammogram. So when you're called back for that whole rigmarole, there's a 10% chance that you will need a biopsy. And of the people then getting a biopsy, only 2 to 3 of those people will have cancer. So 2 to 3 out of every 100 callbacks actually have breast cancer.
Wow, that statistic is, whew.
It just shows you the problem of false positives, right? And honestly, so it's such a kind of darned if you do, darned if you don't situation, because everybody's talking about like, oh, what do you think about this scan or that scan? I don't know if we want to give names and really dive into all these different scans that are like on the horizon, because it's like, well, what are you asking for? So now you want a better scan that's going to find the 2 millimeter cancer? Like, we're already in this problem. And I alluded to wanting to talk about it, and this is the perfect moment. DCIS, so the stage 0 second-line reductive cancer. Yeah, prior to mammography, less than 2% of all breast cancer diagnosed was DCIS, because it was just an, oh, by the way, we see this in the mastectomy we just did, and it has no consequence whatsoever. The second mammography started, fully 15 to 20% of all screening detected breast cancers are this DCIS that we never even paid attention to. And now this year, 56,500 breast cancers are going to be DCIS. 310,720 are going to be invasive cancer. Back to the others, though. That's like 2 million women in the last 4 decades that have been subjected to this, like, oh, DCIS, it's cancer. Like, we should cut it out. We should radiate. You should take tamoxifen and be thrown into chemical menopause and have all these quality of life issues. And, oh, I'm sorry that you're 32. I guess you can't have kids now. Like, so much damage over something that infrequently progresses to invasion, maybe 1/3, 2/3. So 1/3 of the time it'll progress to invasion. But then if you just cut it out, it's gone. So what are the chances it's going to come back? Do you really have to radiate? I mean, this is where it's very nuanced.
Yeah.
How much are you going to take a sledgehammer to something that just needs a little tippity tap? So overdiagnosis is a real problem that then leads to the conundrum of overtreatment, because we have so many things in our bag of tricks to throw at you, but do you need them? This is where I love genomics. This has been on the stage and in the bag of tricks since the 2010s. And this is where different companies will have their own, version of this, but they're analyzing different genetic alterations within the tumor to answer the question, like, what's the % chance that it's going to come back in 10 years metastatic? Oh, it's this %. And if you do chemo, that drops it to that %. So is this drop something that resonates with you? Like, is it worth the chemo to you? In the case of DCIS, we have 2 different tests that will be like, this is your recurrence risk if you radiate. This is your recurrence risk if you don't. And does that drop matter to you? Are you going to radiate? But, there's a world in which patient preference dominates, but it's somewhat illogical sometimes and more of an emotional decision, but it's one that people make a lot regarding this DCIS. And that's why I just want them gone. They're time bombs. They're trying to kill me, and I'm going to win this battle. So bilateral mastectomy with reconstruction for a centimeter's worth of DCIS that may never have progressed to invasion if you had never found out about it, if you had just never gotten that mammogram, right? It's something that I help.
So tricky.
It's so super tricky. But on the flip side, in the same breath, people are like, oh, I'm so glad I got that mammogram because it was only 7 millimeters and it had no estrogen. It was estrogen negative. It's an aggressive one. And now it's smaller and more curable. You really can argue these things both ways. So I'm going to give you.
The problem is, as you point out, it's damned if you do, damned if you don't. Right. And if you don't do it, then something happens, then you hit yourself for not doing it. And we all know that the progressive invasive disease is a challenge. right? And so people feel like, and and I get it, they'll say to me often, well, I'd rather just get it out because I don't know what will happen.
Right. And that's where I love to shine in someone's life, because they get really confused. Like, they usually they're okay with get it out, because that just seems to like make sense. And then everything else we can do through diet and lifestyle choices can alter your cell microenvironment, the fluids and cells and hormones and growth factors that bathe and surround cells, either being pro-cancer or anti-cancer. And I can help shape your life and world to create an anti-cancer microenvironment. So much so that maybe you really don't need all that other stuff.
Yeah.
The radiation, the chemo. Now, there are over 21 subtypes of breast cancer, and some of them you're just not going to kill with kale. You are not. They're really aggressive, and they had somewhere at least a 5-year head start, maybe upwards of 20 plus years. Head start inside your breast when you had no idea it was in there, busy proliferating, getting its estrogen. Do you know breast cancers have their own little aromatase, that fat enzyme I was talking about? They're like, oh, I'm just going to keep this in my little backpack. I'm going to make my own estrogen. I don't even need you to do that for me. It's going to create its hypoxia, create its acidity, create its IGF-1. Like, it has this microenvironment that also requires two requirements always. IGF-1 we talked about, the other angiogenesis. Angio, blood vessel, genesis, birth, the birth of new blood flow to them. These sinister little cancer cells, you have no idea. It's so tiny. You didn't know what was happening. The mammogram didn't see it. Nothing sees it. Building its mission, which is to bring the highway to me, all the nutrients I need, and then I'm going to get big enough to just boom, metastasize straight out through those same blood vessels. So
important to realize that some cancers, when we look at them, we can't just say we need to deal with it. We can't just change. We can't just say, oh, it'll just go away if I eat better, or if I just eat kale. To your point of kale will not make it go away. You have to have an aggressive plan. You need to have it taken out, and you may need therapy, and we need to be okay with that.
Right. And as the field of genomics evolves, I think we'll finally be able to hone in on the correct biology of tumors. Right. So we have indolent, lazy, slow biology. That's the tumor that will kill you when you're 200. That's the one that now you're a victim of overdiagnosis. So let's just pluck it out so you don't have to stress about it, but maybe just live a little better, like wake up call kind of stuff. Like, let's not go crazy. I want to talk about sensitivity. So this is the different modalities have a different level of being able to find cancer when cancer is present to find. Sensitivity of different tests. This will help, I think, you guys figure out what imaging you want to get. Because really, when I said I want to just put a bow on it, exhale. These are all just tools at your disposal. I'm never going to condemn you if you don't want to ever get a mammogram, but don't do nothing, right? Because you can pretty easily feel like a 2-centimeter cancer. Anyone should be able to find that unless it's way back at the back of your breast by your muscle. So don't ignore cancers that are sizable and there to find with pretty simple detection tools, because there is such a thing as curing cancer that you would have died from in your normal age span. And we don't want to miss that opportunity. So here's a quick rundown of the basic tools that we have. 2D mammograms. These are all digital now. The screen film's passe. 2D mammograms, out of every 1,000 women screened, will find 5 cancers. If you do a 3D mammogram, which the difference, okay, let me take your breast. Let's pretend your breast is a loaf of raisin bread. I'm going to squish it and take a picture and try to count how many raisins there are, versus a 3D mammogram. From your point of view, same single squish, same photo that had just a smidgen more radiation. But as the reading doctor of this mammogram, I'm seeing each slice of raisin bread. I can slice through it 30, 100 times, and now I can find all the raisins. That's the difference between 2D and 3D.
Nice explanation. 3D. Yeah.
Thank you. 2D will find 5, 3D will find 6, maybe 7. Okay, so tiny uptick. If you do a mammogram, 2D plus whole breast screening ultrasound, which is one of my favorite tools, because no one's going to reject an ultrasound. It's literally a sound wave through like this soothing warm gel. Like there's nothing harmful about it, except the false positive that leads to a biopsy that you didn't need. But the point is, you add ultrasound to a 2D and your 5 cancers will go to 8. You add screening ultrasound to your 3D and your 6 or 7 cancers will go to about 8. So if the only mammo available in your area is 2D, or they're charging you too much, because sometimes it's like insurance won't cover it and they want to have you do the upcharge on a 3D and you can't afford it, don't fret. Do a 2D plus screening ultrasound equals 3D mammogram. So that's one thing to know. Good. Now we have a couple more specialty tests, but the one that most everybody knows about is a breast MRI, and that's the best. You'll go from your 8 cancers, mammo plus ultrasound, to 19 cancers, same 1,000 women.
Wow.
So MRI is truly the way to go if you are very high risk, but it requires a gadolinium injection into your veins, which is a heavy metal that has been found to pool in people's brains and livers, and it's not an antioxidant. We don't really know what it does there, but it's a heavy metal. They've changed the formulation. There have been no repeat cadaver studies to say if it's still pooling in people's brains with the new formulations. So possibly they're safer, but that's one drawback. Second one is claustrophobia. It's 45 minutes in a clanging tube, and if you don't like being in that situation, you're going to stress out and have an anxiety attack. And the false positives are a beast to deal with. So again, false positive means, oh, there's something there. We better find it and hunt it down and make sure it's okay. But in the end, it's falsely positive. It's benign or disappears. This just leads you often down a big rabbit hole because it's an MRI. So now we got to find something more friendly to find whatever the spot is. And by friendly, I mean a mammogram or an ultrasound. And if it's really there, doing a biopsy guided by mammo or ultrasound is way easier on you and the radiologist versus an MRI guided biopsy. Pure human torture. Like, never once in 24 years have I had a patient say, that was easy. Yeah. But if you find something on MRI and it's really there and you can't find it on anything else, you have to use the MRI to biopsy. And that's never fun, but
I can vouch for that.
Did you have an MRI guided biopsy?
I did.
Oh yeah. Oh, okay. Yeah. So
because they couldn't figure it out and they could only see it by MRI, and they were pretty sure it was just fibrocystic, but they wanted to be sure. And it was one of those, I don't know. I didn't want to be, you feel small for sure. Even as a physician, I was blown away by how small and I felt in this process. And you do it because you don't want to be wrong.
Absolutely.
Yeah, it's a tricky thing. So,
yeah,
Kristi,
I was just gonna say, even the best diet and lifestyle doesn't make you bulletproof, doesn't make you cancer proof. So you should follow your instincts and get answers when they're needed.
Yeah, I don't know. I've had a lot of interesting thoughts about sort of life and sort of these, and I eat as clean as it gets, but it's not everything is perfect, as you say. And I do encourage the audience to listen to the doctors. And if they tell you that they think there should be something done, think about it, maybe get a second opinion. And if you're getting a lot of consensus that something should be done, then we don't want to miss things either. So it's very tricky. I find this area super tricky to sort of say like when, and so finding a Dr. Kristi Funk around would be probably a good solution to kind of figure out what to do and when. Kristi, you've been amazing. Thank you so much for your time and your education and advice to women and just all the stuff you do, because I think that you are not only great energy, you know what you're talking about, and you really think about the patients individually when you make your decision. So I think it's pretty awesome to see. So thank you for spending your time with us today.
You're very kind. Thank you for having me.